We're going to transition now to the panel, the section of the meeting that I am most excited about, the Community Partner Panel. We want to say thank you in advance to all of you who have joined to be part of this panel today. And I'm delighted that our co-chairs for the steering committee, Dr. Cindy Thompson and Natasha Askelson, will be moderating this panel, and they are the respective PIs of their collaborating centers as well. So I'm going to turn it over to you guys to introduce our speakers on the panel, and we hope that this will be a really informative and interactive session. So, Cindy and Natasha.
So thank you. Natasha and I are really excited about the group of people who've come together today for our panel. And again, just to reiterate what Stephanie said, we are so thankful you're here. These individuals are highly qualified and committed to cancer control and survivorship. The bios were attached to the materials and the Zoom link for today, so look at the detailed bios there. I'm just going to quickly go through each person's name, and I don't know, Becky, if you can pull up their picture and the slides. Right now we see your email.
Oh,
yeah,
sorry.
We're seeing the wrong screen.
Okay, sorry about that.
We know that Becky's very busy.
She's just going to make us look good. So yeah, that helps us look better.
All right, here's our amazing panelists. All right, leading off is Nikki Hayes, who is the branch chief at the CDC Comprehensive Cancer and Control Branch. And she's been in the area of chronic disease prevention and health promotion since 2002. What amazed me most in reading this is that she implements or leads the implementation of the National Comprehensive Cancer Control Program. What a huge undertaking that is. So be sure to read more about her on her bio. The second speaker is Dr. Kelly Wells-Sitting, who is the executive director at the Iowa Cancer Consortium. This is a consortium of 500 Iowans, so amazing group of people that she's working with to address the cancer burden. And then our third speaker is Dali Adukunle, who's Director of Patient Relations and Community Partners with the Family Health Centers at NYU Lagoon Health. And she, I just had to point out, is not only in this leadership role, but a science editor and an award-winning healthcare essayist. That's amazing. So I love people who have such diverse skills. And then our own Arizona, Patty Molina, who is the Senior Director of Community Health Services at our Mariposa Community Health Center in the border community of Nogales. She has been instrumental in engineering the community health worker delivery, and I get the privilege of working with her on a regular basis. So thanks for being here, Patty. And then our final speaker who has joined us today is Wilhelmina Matthias, who is co-chair of Trinity Baptist Church Health and Wellness Ministry in Columbia, South Carolina. And she co-chairs the Health and Wellness Ministry and sings in the Jubilee Choir. So I'm always impressed by people who can sing. So thank you so much, all of you, for being here. I'm going to turn it over to Natasha to do further introductions of your work.
Great. Thanks so much, folks. Thanks for joining us. We're going to let each panelist spend about 5 minutes introducing their work and their role in their work. And then we have a series of questions we're going to ask them, and then we'll open it up for you all to ask questions. So Nikki, I'm going to let you go ahead and start, and you will know that you will be prodded if you go over time. I have to be the little timekeeper person.
Oh, absolutely. Thank you, everyone. And I won't go over time. But I do want to say, first of all, thank you for asking me to join you today on this panel. I'm excited to be here, not only to share what we're doing here at CDC, but most importantly, to hear from you and to hear what you all are doing and how we can work together. As was mentioned, I am the chief of the Comprehensive Cancer Control Branch in the Division of Cancer Prevention and Control here at the agency. And we do manage the National Comprehensive Cancer Control Program. It's one of the flagship cancer control programs in the agency. And our program really focuses on this coalition-based approach to cancer prevention and control. And so it's grounded in partnerships, it's grounded in collaboration. And it's a program where we actually fund state health departments or their bona fide agents right now to convene coalitions and then have coalitions work together, assessing the burden of cancer in their communities, coming up with a set of priorities, putting those priorities into a cancer control plan. That's a statewide plan, a jurisdiction-wide plan, and then working together with stakeholders from across the state and the community to implement the priorities in the plan. We fund programs in all 50 states, the District of Columbia, and then we also fund 8 tribes or tribal organizations, and then 7 U.S. territories, Pacific Island jurisdictions. The programs are now in their 5th year of their current funding, and just yesterday, the application period for the new funding opportunity closed, and so we will be looking forward, I guess, to reviewing all those applications and making funding decisions, but are really excited that we get to fund this program for another 5 years. We started the program in 1998 and are really, really proud and happy and excited about the work we've been able to accomplish through very, very, very important, critical, essential, and valuable partnerships across the country. The funding is a collaborative cooperative agreement. And so we work very closely with the recipients for the National Breast and Cervical Cancer Early Detection Program, as well as our National Program for Cancer Registries. And theoretically, and in most cases, it does work just like this. They all work together to assess burden of cancer and then support each other in implementing their individual program program expectations. We are focused on prevention. Primary prevention, we're focused on early detection, focused on survivorship. In fact, we just over the last 3 years provided additional or supplemental funding to those applicants who were interested to really help them hone in on some of the activities and that they could do to really impact the quality of life of cancer survivors in their communities. And what that looked like, for the most part, it looked like implementing the survivorship module of the Burford survey more often, and then taking that information and using that. It meant working with providers to really focus on how general providers can treat cancer patients or cancer survivors as they return to treatment. It focused on helping to create these community clinical linkages so that survivors could have places in their communities where they could go to get the support that they needed to be able to live healthier lives. We also focus a lot on health equity as one of our program priorities. And I will say over the last 2 years, we've really begun to really shift and try to figure out how we can provide more support towards looking more at those upstream barriers, those social determinants of health that really do influence health and health outcomes in specific communities. And we really do ask the programs to focus on this policy or systems, environmental change based interventions, rather than focusing on trying to change individual behavior, but really looking deeper at the systems that are actually impacting behaviors and influencing behaviors, and seeing how we can leverage those systems and leverage changes in those systems, whether that's big P policy or small p policy, to really make a difference. And then evaluation, of course, is always at the core of the work that we do. We cannot do any of the work that we do. Our funding is it's nominal, and it really is there to really provide the infrastructure. So it provides the support to convene the coalitions and then support the work of the coalition. But we also work very closely with our national partners to include, we have a cadre of 19, there are 18 of us now, that have been working as a solid unit since the program was started in '98. And we have really been here to help support the needs of the coalition and support the work that they've done. And over the years, we have done quite a bit of work that many of you in this network or our previous awardees have really helped and worked with us to do. Examples would be a few years back, we hosted these leadership forums where we wanted to bring together the cancer control partners in the state with healthcare association and with federally qualified health centers, with immunization programs, with other partners and players in the state, and really help them focus on, we had 3 different priority areas. One was around increasing HPV vaccination uptake. Another was around colorectal cancer and increasing colorectal cancer screening. And then the third initiative that we focused on was around smoking and health. And it was around, this was an opportunity that we had with our colleagues at HUD, but we really focused on how we could help our colleagues at HUD to implement smoke-free housing and how we could use cancer prevention messaging to help to influence adaptation of the new rules that had come about. But it's an example of how cancer coalitions can partner with others to really make a difference in the community. And this network has really been instrumental and helping us to provide some of the expertise that we've needed at these trainings, these action planning trainings, some of the expertise that we need on the ground in our evaluation efforts and activities. And even in trying to figure out best practices of how we implement and adapt interventions to address or to meet the needs of a specific community. We also have. I'm
gonna stop you just so
I see my minute.
Okay. Plenty of chances to share your good work. We got a lot of questions for you. Want to make sure we get those.
Okay.
I'm super excited to be able to introduce Kelly. I am very honored to call Kelly a colleague and a friend. So take it away, Kelly.
I feel really honored to be here today with all of you and some of you whom I know and some who I hope to know in the future. So thanks for having me. And it's also an honor to follow Nikki Hayes. And that's really a perfect setup for me to tell you about the work of the Iowa Cancer Consortium, which is where I serve as the executive director currently. So Nikki talked a lot about their really important work and funding of state cancer coalitions, and hopefully all of you are familiar with your state coalitions. If not, I encourage you to be. They all look different. There's one in every state and many tribes and territories. Everyone is kind of like a different animal, but they all are made up of folks who are really passionate and driven around comprehensive cancer control. So it's a great connection for people who are looking to make relationships with others in cancer control and community members. And I'm going to tell you a little bit about ours in Iowa today. So we are really lucky here in Iowa to have a pretty robust coalition. And I like to talk about our structure a little bit first, just because I think it explains how we're able to do some of what we do. We're a nonprofit organization here in Iowa. We have about over 500 members actually now, and those are individuals and organizations who have chosen to align themselves with cancer control within the state of Iowa, all at different levels of activity, of course. We are funded primarily through a grant from the Iowa Department of Public Health. So Nikki talked about the cancer control programs. We're funded by the cancer control program at the State Department of Public Health, primarily. We do have some additional streams of funding, but that's our primary source of funding. We're also housed at the University of Iowa, Holden Comprehensive Cancer Center. So we pay some of our grant funds to the Cancer Center to provide staffing and infrastructure support. And what that means is that we're a nonprofit coalition in Iowa funded by the State Department of Public Health primarily and housed at a cancer center. And it sounds boring and dry to talk about structure that way, but what that actually means is we have this really wonderful three-pronged foundation of partnership already built into what we do. And I think you'll see how that plays out as I talk a little bit about what it is we do. I mentioned our members, they're at the heart of our work. They are the reason that the coalition exists. We recently went through a strategic planning process, which helped us explore exactly what our members are looking for right in this moment. And our members, again, are people either working in, researching, advocating for cancer control in some way. So a lot of people at the professional level, cancer survivors, community members, there is a really wide range in that 500, in those 500 people. And what we found out most recently was that people are looking for, right now in our membership, connection and networking, which makes sense in a coalition. They're also looking for an increase, like a way to build their skills in advocacy and in policy systems and environmental change. They're really focused on how to start working health equity into the work that they're doing at their public health department or at their healthcare system or within their church community. Again, it's very broad, but these are the things that they've identified for us most recently that they're looking for. And so those are our focus areas right now. Now, of course, really our focus area is the spectrum of cancer control, and we do address all of the areas within the spectrum of cancer control, but layered on top of that are these areas that we're trying to increase focus for our members. A few of the ways we do that include statewide work groups and committees, and those are more topic focused. So those include things like policy, health equity. We have a clinical trials and research work group, rural, radon, colorectal cancer, HPV, and quality of life. And hopefully I didn't leave one off. Possible I did, but I don't think so. And those are places where people can come from across the state, come virtually, and we meet virtually, to connect with others. And I think that's a really important piece to point out to this group, because it's also a place where folks who are interested in research can come and meet with people who are in the community. Because we have such a wide range of folks who are members of the coalition, we do have overlap within these groups. And so it's a way to start building relationships. We revise and work to implement our Iowa Cancer Plan, which we're getting ready to revise for 2023 right now. So Nikki mentioned the cancer plans as well, and our coalition does lead the revision of that. We also provide what we call Iowa Cancer Plan implementation grants, which provide funding up to $25,000 to organizations and communities who are implementing something within the cancer plan. And then we try and provide capacity building and communication support for our members. And that might be through a conference, through a webinar, through coordinated social media message sets that we provide to our members or other resources. And then the last thing I want to mention as a way that we're delivering on our mission right now is we've just engaged. So we focus statewide, but we also know that there are populations within Iowa who can use more support and connection. And so we have engaged with 2 8-hour per week contractors to help us focus specifically on populations. So the first is the Black or African American community in Waterloo. We've engaged with somebody in that community to provide outreach and engagement in that area. And then we've also recently engaged with somebody to focus on rural communities in Iowa. So doing the same things the rest of our staff does, but focus specifically on those communities rather than on the state.
Thank
and
you, Kelly.
Am I done?
I'm sorry.
I was just about to talk about you, Natasha.
No, don't. It's time to move on. We're not going to take an airplane out of the Midwest and we're flying to New York. So
Okay.
Dali, you're on.
Hello, everyone. It's really a pleasure to be speaking with this team today and to be a part of this panel. And just to introduce myself again, my name is Dali Adekunle, and I'm the Director of Patient Relations and Community Partnerships at the Family Health Centers at NYU Langone Health. The Family Health Centers at NYU Langone Health is a community-based program that provides high-quality primary and preventative outpatient care to adults and children, regardless of their ability to pay or their health insurance status. Our Family Health Centers was founded in 1967 and has really grown to become one of the largest federally qualified health center networks in the entire nation without isolating our connection to the community. We are home to the largest dental residency program in the country, the largest school-based health program in New York, and with over 100,000 patients, our network handles 600,000 doctors' visits each year. Our network of Brooklyn-based community health centers includes 8 primary care centers, specialty sites, and more than 40 school-based health and dental clinics, with a wide array of social support services for adults and children and families housed in our family support center. So we're really looking at taking care of the holistic health environments of our patients, understanding that healthcare is not isolated from a host of insecurities like immigration insecurity, housing insecurity, and food insecurity. Our treatment areas are pediatric care, I've mentioned, dental care, behavioral and mental health services, rehabilitation care, primary and specialty care for adults, and obstetrics and women's health services. In terms of our cancer prevention focus, we're really focusing on breast cancer, colorectal cancer, and lung cancer in Brooklyn because we see a rise in those cancers within our patient population, especially our population is really indicative of the diversity of Brooklyn. So where the Family Health Centers is housed in Sunset Park, we have a wide array of races, ethnic groups, and nationalities, Latinx patients who are of Asian descent, Mandarin-speaking patients, and African-American patients. So we partner quite often with the Perlmutter Cancer Center in Sunset Park to provide an entire scope of services for patients that include free cervical cancer screenings, free colorectal screenings, and also lung cancer screenings. So that's really the basis of our work within Sunset Park and within Brooklyn. And I'm excited to be a part of this panel because I want to share my insight as a healthcare leader liaising with my community every day. You know, I'm really an individual who has boots on the ground every day, hearing operationally how we need to improve, but also what needs are present within our patient community. Thank you so much.
Thank you so much. We're very excited to have you here too. So I'll get back in our airplane and travel back across the country to go to Arizona. And Patty's going to share with us what she does.
Hi all, so I'm Patty Molina, Senior Director of Community Health Services with Mariposa Community Health Center. Mariposa Community Health Center is a federally qualified health center that was established in 1980 to meet the needs of the rural, low income and Hispanic Latino populations that we serve in Santa Cruz County. Currently, we have 5 clinical sites. And if you're not familiar with Arizona as a whole, Santa Cruz County is the smallest county in the state of Arizona. We have 5 clinical sites. We have 2 in the main city of Nogales, Arizona. To the north of us, we have 1 in Tubac, Arizona, and then another one in Rio Rico, Arizona, and then a last satellite clinic in Patagonia to the east. So with the Community Health Services Department that I oversee, it was established back in 1991, and it has a well-established community health worker delivery model. We have 33 staff within community health services, a total of 24 community health workers within my department, but the clinic itself has a total of 39 made up with our WIC services, CHWs, and then our care coordination as well. With my department, my CHWs implement a spectrum of health promotion and disease prevention programs based on model programs and best practices adapted to the Spanish-speaking community that we serve. We use evidence-based curricula, and we train each of our CHWs depending on the actual program or chronic disease management program that they're going to implement. My department is 100% grant funded, which is, if you hear 100% grant funded with something, is always really scary. We have state, federal, and then private foundation grants. And right now, that is our main focus, is trying to ensure that we're continuing to find funding that is going to be able to provide these really needy programs to the community that we serve. One of the unique things that we have in terms of our service delivery model is the use of teen health, community health workers. These young community health workers are trained in the summer in a program called Summer Youth Institute, and they do peer-to-peer outreach on risky behaviors with teens in this area. It's really great because we hire them after school and they're able to continue to do the work that they're doing. Primarily, the department in our community health services is known as Platicamos Salud, and it translates roughly into We Talk Health, and that's how everyone in the community really knows us. Really, we're an important extension of the clinics, the clinical services, connecting, referred patients to additional education, support, and follow-up that is culturally competent and language appropriate. If any of you work with community health workers, you know how important that could be. The majority of the community health workers are also trained with our electronic health records. And so they're able to, once they get a referral for any of the programs, they're able to reply back in that electronic health record to the providers. The provider knows what type of extended education they may have received, whether it's for diabetes or asthma or, referral to quit smoking or anything else. Basically, our community health workers are really the heart and soul of the department. They wear many hats and they do a variety of activities, including home visits, neighborhood recruitment, community assessments, health education, facilitation, patient care coordination, and so much more. I won't go into a lot of details in case I get asked any of these questions, but I'm always available if anyone has any questions. But for now, I'm just going to stop there.
Thank you so much, Patty, and you have a wonderful background. We're going to now go east again. Wilhelmina from South Carolina.
Hello, everyone. Can you hear me? Great. I am pleased and honored to be able to talk about what we're doing here in Columbia, South Carolina. I am the co-chair of the Health and Wellness Ministry of the Trinity Baptist Church. And what we have been doing is working to educate the community, not only our congregants, but the community about their health. Let me get this off my screen right quick. About their health. And due to COVID, some of our congregants have been not only affected by COVID with themselves and family members, but I think the fear of the unknown and fear about the virus, the vaccine. So we've offered education to our congregants and the surrounding communities. We have initiated programs that will attract them in terms of taking ownership for their health and their health disparities, and try to eliminate some of their concerns in terms of coming out and social distancing. We have implemented programs, educational programs, not only for our congregants, but for the community and for other churches as well. And we've done that through email. We've accomplished that through Zoom. We have pamphlets and brochures available, and we've made ourselves available for them to call and ask questions. Our primary focus has been to ensure health and wellness opportunities for the congregants, letting them know what's available in the community, what resources are available, and how they can, even though COVID is active, alive, and well, that they can still take ownership for that, for their health, with our assistance, of course. This off my screen. Some of the challenges that we face is COVID. And is notifying or informing them, our congregants and the community, that we are here, we will answer questions, but we will also offer services. And we've partnered with different organizations such as Walgreens, Palmetto Dentistry, Right Wellness Center, AIDS Healthcare Foundation, South Carolina DHEC, Trinity Baptist and other churches, the American Cancer Society, Mental Health, Best Chance Network, and I want to speak just a minute on Best Chance Network. They have made themselves available to work with congregants and the community who are uninsured, which has also been one of the problems that we face. A lot of our community members don't have insurance. So they have provided resources for them to come and get screened, to come and have mammograms. So with that being said, we are just continuing to revise our programs in terms of COVID, because we've had to reschedule. We had the mammography ban come out, but we've had to revise and reschedule that due to COVID. So right now, our church is not having any events. So we've had to push the dates back. But that gave us the opportunity to establish closer relationships with the community and those folks who are interested in receiving mammograms, which I find to be quite helpful, and it was resourceful to establish that bond so that those persons will come back in April to have their mammogram. And that's about all I have to say in terms of what we're doing. We've just tried to take the challenges that we face and turn them into opportunities, not only for our congregants at the church, but for the community as well.
Thank you so much. So now, Cindy and I are going to kind of dig deep and play Phil Donahue and Oprah Winfrey. And I think what we're going to do, we want to make sure we have plenty of time for you all to get your questions. So we're going to ask some of our questions that we've already thought about, and then we'll break. I'll let you all ask some questions in the audience. And then if we still have time, we'll go back and finish ours. So I think you got to go ahead and take it away with the first question, Oprah.
Yeah, so Wilhelmina, you really set the stage of kind of this context of current COVID times and the impact it's having. So I'm going to address this to Patty to launch us off. Within the community that you serve, there's so many priorities for healthcare at the FQHC. So I'm just wondering, how are you managing those priorities? How does cancer prevention and control fit into your current priorities?
Thanks, Cindy. So yes, as a federally qualified health center managing COVID-19, this pandemic has been quite challenging, and it has changed in how we deliver care to our patients and how we keep our patients and each other safe. For the most part, our main priority has continued to be patient care in whatever form of medical need they require. At our federally qualified health center, cancer prevention and control efforts are primarily focused alongside our wellness visits for our patients. So either women's wellness visits with screenings during a clinical breast exam, and if of age or family history, a referral for their mammogram. We now have those services available at our FQHC, which is really good. We don't need to refer patients outside of Santa Cruz County. We don't have public transportation in our area. For a lot of people, getting to appointments is quite difficult. So you could imagine if we have to refer them outside of Santa Cruz County, that could really hinder a lot of their care right there. So thankfully, we were able to get diagnostic mammogram now here in Santa Cruz County, which is really great. So that is something that continues there in terms of any referrals for mammogram for breast cancer screening. The same would be for colorectal cancer screening. Both of these are quality measures. As an FQHC, we need to meet annually. So that is another thing that our providers are able to either do the home fit kit test for them and then refer out. Unfortunately, for colonoscopy type services or anything further beyond that, they would need to be referred to north to Pima County, which is where you're at, Cindy. So that would have to be the case right there. But we do offer services such as the Well Woman Health Check program and the Juntos contra el Cáncer program. So Well Woman Health Check program is a free breast and cervical cancer screening and diagnostic program for uninsured or underinsured women in Arizona. And then Juntos contra el Cáncer, that has actually been around for the past 28 years for us, provides breast cancer support, access to care, patient navigation, and survivorship. We actually have a large group of breast cancer survivors that would normally meet on a regular basis. The last 2 years has been very challenging. We've been able to connect with each other virtually, but it's just not the same. We do also offer prosthetics, undergarments, turbans, and wigs, and all of that is free of charge, like I said earlier, because we're 100% grant funded. All of the services that we offer within my department are completely free of charge, regardless of whether they are a patient of Mariposa's or not.
So it sounds like you feel like the priorities have not shifted a lot. They're really just, some of them have been a little difficult to deliver.
Right. Mm-hmm. And even care-wise, for example, we shifted some to telemed appointments depending on the severity of whatever they needed an appointment for.
Thank you.
So I'm just wondering if each of you in like a sentence or two could indicate if there are new priorities that you've discovered related to cancer prevention and control over the last year, or a priority that has changed. So thinking about your organization and the people you serve, just a sentence or two really quickly about how things have changed in terms of priorities. I'm going to go to Wilhelmina first. I think you're muted.
Okay, can you hear me?
Perfect, thank you.
Okay. As I mentioned, COVID just has played a major role in the service delivery for our health and wellness ministry. And I think that in the beginning, with the vaccines as they were presented on TV, our communities have got some misinformation in terms of the vaccine and what it can do. And we still have folks who are very reluctant about receiving the vaccine, even though we offered it at the church. So I believe that really played a major role with our program, with trying to make sure that the community had resources. And we even provided transportation to the church with social distance. So, you know, the appointments were scheduled, you know, with time to really sanitize and, you know, and all of that. But COVID was it just played a major role. And you know, as the numbers decreased, we thought that we were going to be able to offer more services. But then as the numbers increased, we just had to back away and revise our program and see how we could reach the community and what we could do for them and be a resource. And even though we can't actually have any programs at the church right now, Zoom is still alive and well. As you probably already know. So, and then the phone is available. We can call them just to check on them, to say, you know, we're thinking about you. We can't offer any services right now, but let us know if you need anything. So we have just tried to still remain active. We've also sent notes to them through the mail, just letting them know that we're thinking about them and just, you know, trying to keep the lines of communication open.
Thank you.
Thank
Nikki,
you.
how about from the funder perspective?
I think so. We've had to make a lot of adjustments. We've had to help our awardees pivot. And so we've had to kind of relax and or look at how we can adapt our expectations so that awardees can get the work done in any way that they can or cannot. And a lot of times that meant partnering different. It meant being more creative around how we use the resources and the funds. And most recently, we really have still focusing on screening, early detection, but really looking at how we can help to message the return to screening messages and how we can help to get them out. And another opportunity that we have, or a silver lining, is really looking at health equity and beginning to talk more about and do more about looking into how race really does play a role in health and health inequity, and really supporting programmatic work to examine that and really to face those challenges head on.
Thank you. Patty or Deli or Kelly, any one of you want to jump in on this one as a last call?
I do. I just want to jump in and piggyback off of what Wilhelmina mentioned. I think a new challenge that we've discovered is that the vaccine hesitancy about the COVID-19 vaccination, how its dilution and influence has actually affected HPV prevention within our population. So a renewed interest and a renewed priority of ours is increasing counseling and access to Gardasil vaccination among individuals who identify as women, or individuals with cervixes who qualify. So that's 45 and under, and not being previously vaccinated before.
Thank you so much. Cindy, I'm going to turn it back to you.
Yeah, I'm thinking, I've heard a couple things like Dolly and the HP vaccine efforts, Patty and the telemedicine. Can you share other kind of bright spots that have come out of this whole COVID challenge?
Personally to me?
Any of you.
Well, I will mention a bright spot about the help that our family support service has really been able to provide our patient community. You know, the shift to telemedical services was something that is novel, and it's fantastic that healthcare networks all over the nation were able to shift to it. But in addressing health equity and social determinants of health, one of the social determinants is access to affordable internet service and reliable internet connection. And so one of the things that our family health centers was able to provide our patients was free broadband connections and free broadband services to our patients. In addressing the fact that, hey, we're pushing them to this one modality, but we're not supporting them to accessing that modality. In addition to that, we receive grant funding to provide our pediatric patients with iPads that could help them with their remote learning, and also provide them access to pediatric care. Same with some of our patients in our behavioral health centers. So I'm really finding that structural support to provide, internet access, but also access to the correct technology.
Kelly, how about you in terms of the state cancer plan and your activities? Was there a positive that you've noted?
Yeah, I think so. One of the things, so part of what we do here is help people, build relationships with each other. And we were actually really surprised really throughout the pandemic so far that people may have Zoom fatigue, but they're also really hungry to connect, especially early on. They're looking for connection, I think, for a lot of reasons. One, because we're all feeling a little bit isolated, but two, everybody, they want to find peers who are going through the same things as they are. And so we expected people to have to put consortium involvement on hold because they had to deal with COVID. But what we've actually seen, I would say, is an increase in engagement and involvement. And I think it's because now more than ever, we have to rely on each other, and everybody is feeling that some way or another.
Important perspective.
Yeah, I think you have started to answer some of our future questions. Like, you might have seen the questions before. So moving away from the pandemic focus at the moment, what are the biggest challenges that are currently facing your communities in regards to cancer prevention and control? that aren't COVID related, that may have been there before, or maybe new things that have popped up, but they're not COVID related. Patty, do you have some thoughts on that?
So, screening is a huge one, and ensuring that patients come in for follow-up care is one that I would say. Some of the points from handling the pandemic and how you manage patient care, can be tied into some of these challenges as well. Even if we're trying, it's kind of really hard to try to move away from the pandemic when you're at a federally qualified health center, because you're managing healthcare day in and day out, no matter what that looks like. So you're not just managing all those COVID patients, you're managing everything that's there. So it's already challenging to get women in to come in for their preventative care and screening. The majority of the population here is Hispanic, so it's common to only go to the doctor when something is wrong. Women, that we do not prioritize, as women, we don't prioritize a lot of this care. Sometimes as mothers, you also have other challenges. You care for your family first before you even care for yourself. But that's one of the big ones with the Hispanic population, is you only go to the doctor when there is something wrong, or you feel something that's severely wrong, and that's a really bad thing right there, because you're kind of, the mother is always seen as a matriarch for the family. We also work with a really high immigrant population that they also have their own barriers to coming in and seeking care. But the CHWs try to do a lot of education and provide outreach and encouraging, for early detection and early screening, and that's a lot of what we do. And in terms of us personally, our measures with screening for breast cancer is really good, getting women to come in for their mammograms. Cervical cancer, our cervical cancer positive population has not been very high. We don't have a lot of worries right there. Colorectal cancer has been one where we have not been able to meet that measure, and that's just one of the things that we've been trying to work with really closely right now, or trying to focus on that with Cindy and a lot of the group at the University of Arizona, and then some of the efforts that we've been doing as well within our community.
Cindy, how about one last question from you, and then we'll open it up to the audience.
I was going to actually grab a chat question about this whole vaccine hesitancy, right? Wilhelmina talked about the COVID vaccine, but we're wondering, has it impacted HPV vaccine in uptake at all for any of you? Sounds like, anybody want to answer that?
So no, I think we're working really closely with our area health education center, our area AHAC right now on a COVID vaccine hesitancy grant that they have gotten, and our CHWs are out doing a lot of outreach and education on that. I think our biggest barrier has been the COVID vaccine hesitancy there, but not on anything else. I think that people are coming in, even the flu vaccine, the campaigns that we've been doing around that, people are coming in for that. And even now we're continuing those efforts right now, and we're going to continue to ensure that we have the word out that flu vaccines are still available and still important, at least up until April for us.
Okay.
And I know that, here at the agency, we have been talking with colleagues in the Immunization Services Division, because we've been collaborating with them for years now on how to use cancer prevention messaging to increase HPV vaccination uptake. And we're really concerned, when we saw the numbers begin to dive during the pandemic. I think what's refreshing is that we are seeing them increase now, not to the level where we were, but we are seeing them increase. And I think the thing that's really great is that we have these very strong relationships with partners who are working now to update messaging, adapt messaging, so that we can continue, so that we can try to get back the momentum that we did have. But I do think it's encouraging. I was really worried myself because there's always been vaccine hesitancy in this HPV vax space anyway, and then trying to worry about, the mixed messaging around what's coming out around the COVID vaccine. And I'm pleasantly surprised that we are seeing those rates begin to pick back up. We just need them to pick back up faster, but it's happening.
Very nice. One of the things, Nikki, that you mentioned earlier is the social determinants of health is kind of driving the funding going forward for the next 5-year cycle. All of you seem very committed to, health disparities and advancing equity. I'm just wondering if you can comment on some of the ways you've tried to address inequities in your work. Anybody? Let me see. How about Dolly?
You called me because I was smiling. One of the ways that we are actively addressing some inequities, and it's something that I haven't heard just yet in the panel, is really meeting patients where they are when it comes to their language. I think, I don't know if that's something that is reflected in some of the populations of the other panelists, but like I mentioned early on, Sunset Park, Brooklyn, is really an amalgamation of so many different racial, ethnic groups and nationalities. So we really try to have that reflected within our employee body, making sure that, we have a diverse employee body, diverse individuals at all members of the patient healthcare continuum, be it, our medical assistants who are Arab American, our front desk staff who speak Spanish, our physicians who are maybe speak Cantonese or Mandarin, and making sure that patients are seeing themselves reflected in their healthcare, and also have access to collateral, either marketing collateral or educational collateral that reflects the language that they speak. Most recently, and I oversee this, we have a community newsletter that is distributed quarterly to our patients. And before, historically, it had only been translated it had only been available in English. And now we have it in Chinese, simplified Chinese, and Spanish to our patient community, with efforts to translate all of that information into Haitian Creole as well. So I think one of our main ways within the FHC is making sure our employee body is diversified, and all of our communication is diversified as well.
Looks like we have a question from Mary White at CDC. Could the panelists speak to efforts to engage community residents in efforts to advocate for environmental and policy change? So the PSE changes, how are you getting people to do that? Kelly,
if I could start.
Great,
so
Nikki.
one of the things that, this is to me what I think is so incredibly invaluable about the Comprehensive Cancer Control Program and the cancer coalitions, because we can use the coalitions we can leverage coalitions to do things that we can't do, and vice versa. And I think an excellent example of the community really stepping in and stepping up is some work that we did through our Comp Cancer program in Louisiana and our national networks in Louisiana, where the state had long been wanting to make New Orleans a smoke-free city, and there were all of these reasons why they couldn't, but they could leverage the community relationship relationships and partnerships. And the cancer program could provide the coalition the data that they needed, not to sway or, but just the real facts data. This is what happens when we don't, this is what happens when we do, and really empower the community to take that messaging. And they were able to do that and influence city planners and city decision makers and get them to make New Orleans, to adopt legislation that made New Orleans a smoke-free city. And it was all because the folks who were working in the casinos, and in those work sites where smoking was not prohibited, they were the ones who really came to the forefront and said, like, I need my workplace to be smoke-free. And this is why. And we could leverage that to really influence. And that was absolutely the community stepping up and saying, this is what I need. And it was more than trying to lean on, the heartstrings of individual business owners and hope they make the right decision. But it was really about taking that knowledge, that information, and that passion, and really implementing policy level changes that would benefit the community.
Kelly, do you have some thoughts from the coalition perspective?
Yeah, absolutely. And again, that's a perfect setup for some things that are happening within our coalition. So we also, of course, don't lobby because we have state and federal funding, but what we can do is provide a place for our members and partners to come together and exchange what they're doing, which allows for amplified messages and new partners and reinforcements. And so we definitely do that through our policy committee. A really good example is that this year there is some legislation that's going to be put forward at the state level focused on radon testing in schools. And it's being named in honor of a longtime consortium member and radon reduction advocate, Gail Orchid. And though the consortium is not for or against any specific legislation, we provide a platform for people to talk about this legislation that's happening so that they can take those conversations back to their own organizations and connect with the organizations that are leading efforts if they're interested in helping to advance that legislation. And we've seen that happen. I think it's likely that this legislation will be passed this year. It's not because the consortium pushes it, but because the consortium has a place for it to for folks to learn about it. Not only the consortium, of course, there are many players involved in making that happen. And then I'll also just mention, the idea of capacity building and resources are huge. Sometimes people just don't even know where to start. And so something that we do at the coalition level is really just try to funnel those resources out as broadly as we can and answer questions as they come in or get them to the right people who can answer questions.
Wilhelmina, I'm just wondering, in the church setting, if there's advocacy that's kind of come out of your church members.
Yes, it has. And we have accomplished that through our neighborhood associations, which we thought was a creative way to get community involvement, not only in where our church is located, but in other communities as well. And we've also presented at their community meetings, of course, by Zoom. Mm-hmm. But that's how we've been able to get the community involved in terms of advocacy. Mm-hmm. And that has worked quite well for us.
Great. There's a pearl from this.
Always.
Looks like the next question is for you, Wilhelmina, but I think there probably are others on the call who could speak to this as well. Can you talk about the relationship between the spiritual and health ministries? I.e., can you use the spiritual to enhance health? Does your ability to connect health and spiritual needs change how you speak to congregants versus other community members?
Are you addressing that to me?
That has been addressed to you. James from South Carolina addresses that to you. But my guess is others on this have thoughts too.
Right. But what we have done since our church services is by Zoom and call-in, we have made that available, an available resource for our the persons that we serve. And even when they come down, when we had the pornography unit at the church. We also let them know that if they wanted to listen to church services, or if they needed anything from the church, we let them know. We gave them the number, the email address, and all of that was provided for them in our handouts. So in terms of spirituality, I know that some of the seniors who have health disparities they're just not comfortable with going to church. And even though they may be used to going to church, that was not something that they really wanted to do. So we let them know that if they did not have an internet, or if they did not have a laptop or desktop, that they could call in, not only for church services, but for Bible study and for any other services. And if they were members of other churches and they needed that resource, we would also provide that for them. So they didn't have to come to Trinity. They could go to their own church. And they may not have known that they could call in and have access to those services.
If I could add to that as well, two of the things that we've done in the national program is, we've really worked with our coalitions, programs and coalitions, to have them to do some real introspective thinking about who is at the table. And is it the right person? And despite, all of our best efforts and best intentions, we did have some programs that said, but when I sat down and thought about it and I realized that I didn't have the right folks at the table to make decisions and to make suggestions about, what we're trying to do to reduce the disparities or the inequities that we see in health in our communities. And so we gave them permission, without repercussion, to change course and say, you know what, as well as I was trying, I need to do this a little bit differently. And one of the things that we've done here in the agency, we have a new opportunity with some partners at the American Cancer Society and a couple of other places to really look at this question around, well, how do we increase colorectal cancer screening in the African American community? And is there a faith-based approach that we could consider in this specific community? And so we have just started a program with AME churches here in Georgia to look at just messaging. What does the member from this congregation want to hear when we talk about why you should get screened and where you should get screened? And then what kind of relationships do we need to build with the clinical community so that those resources are available? And then how can we empower ministers to speak that health message from the pulpit in a way that they feel comfortable? And is that the influence? Is that the trusted? Is that the leadership where you want to hear the trusted messaging? So for us, it's a lot of about trying to learn more about what folks want to hear, what folks need to hear, and where they want to hear it. And then how can we help also to make sure through our relationships that we leverage the opportunity so that when you are ready to get screened, there's that resource in your community to go and do it. So because like we all know, there's no point in me making up my mind, okay, I'm gonna go get that colonoscopy. And then I gotta go 35 minutes away and it's gonna take me 6 months to get that appointment. And what's the likelihood that I'm gonna really see that through? And so really trying to work with our faith community to make sure that we have those community clinical linkages so that we can really not only influence the behavior, but also make the resource available.
Mm-hmm. So we had a question from Betsy Risendale about, and it relates to one of our questions. Just as a network, the CPCRN network, we're here to build bridges for you and work with you effectively. Can you name one or two ways that we might better support you or, help in the cancer control efforts of your organization?
I would love to answer that if I can really quickly. And actually, rather than answer it directly, I just want to brag on the folks from Iowa who are on this call. I know there are lots of them here. whether through CPCRN work or through Cancer Center grants or just the passion in their hearts, we are so lucky to have so many strong researcher, coalition, community partnerships here in Iowa, especially at the University of Iowa. And I think that that is a really beautiful relationship because we fill gaps for each other, I think. So for the coalition, we need the guidance and the wisdom and the knowledge of the researchers, and the researchers need the people of the coalition, and they need those networks. And it ends up benefiting everybody, especially if, you know, we can all hold, meet everybody where they are. So meet each other where we are. And I feel like folks in Iowa, at the University of Iowa, are doing a really wonderful job. Super grateful to them. And so I think that's something that you can do, is get involved in coalitions as researchers. Don't wait until you have a need for research to ask, you know, hey, I mean, we know this, right? Like, don't go to the community and say, hey, I want to do research. Can you do research with me? Like, get involved with your coalition. It's a really great way to meet community members and just start to build those relationships the right way. And you should talk to the researchers on the call from Iowa, because they're doing a really amazing job of that.
Thank you, Kelly, for singing my song. Yes.
Others want to comment on that? How can CPCRN and the network, you know, but yes, your local partners, but even broader, are there things that we could be doing that would be helpful?
I'm thinking just working together and not against each other, and sharing expertise is what's important. I mean, someone somewhere else might be doing something similar that someone else is trying to basically accomplish, and trying to share those expertise with everyone else. Sometimes it's easier to just copycat someone maybe in Iowa than reinvent the wheel in Arizona, for example.
Yeah.
We have a question from Wendy Barrington in I think Washington, right, Wendy? My screen just moved. Related to Nikki's point about community advocating for policy change, would love to hear how community has driven organizational changes to reduce structural barriers in public health or healthcare. So that one's a big one. Who wants to take that one on?
Gosh, I think I can somewhat answer that with the, you know, the whole point that our focus on a lot of the work that we're doing is with the utilization of community health workers that can help in those, you know, just access to healthcare and then that public health thing, you know, just because, you know, they're individuals, CHWs are individuals that, you know, who truly reflect the culture, the linguistic and socioeconomic characteristics that are in my border community where we're at. So really, you know, they're the ones that know where the community is, and they go to the community, and they can also reach segments of the population that's really hard to reach, and just really try to enforce a trust within neighborhoods and communities. I mean, pre-COVID, we used to have what are called cafecitos, or coffee time, where we had individuals at somebody's home in a neighborhood, and they would just share talk and experiences and referrals to resources that they may not know exist. And so those are barriers that we're trying to focus on with, you know, social determinants of health that they're having to deal with, that, you know, they don't know that there's resources available for them, and then just bringing them in and making sure that they're not scared because of either immigration barriers or anything else that might come into play. So.
And I think that we've also seen something very similar, you know, even at CDC and our colorectal cancer control programs, you know, where we might have, we fund, you know, a state or a jurisdiction to partner with FQHCs to really look at, you know, what are their systems that they have for bringing in folks and getting them screened on time, and really like working with them to implement like the use of client reminders and provider assessments, and changing, creating, the system support that they need to do that, and really showing that the more you implement and incorporate these interventions into your daily strategies, that the more you are able to increase screening within your patient population. And then we've seen instances where they've seen that work, and these FQHCs have actually adopted those practices into their everyday work, so that they can use that as a way to increase and get to the HEDIS screening measures that they need, where they need to be. And so, really working together, with the state health departments, the programs that are on the ground, to see how and where we have opportunities to help to influence these organizational changes.
Thank you.
I also want to mention something real quick before we move to another topic. I believe it's really important. This is tangentially related to Patty's comment about having community health workers be demonstrative of and reflect the patient community. But I also think it's very important to have members of the community be reflected in leadership. And I think that's why the family health centers is really a gold standard, I believe, in among FQHCs, because we have a board of directors who actually use our services, and board of directors who have been a part of the Sunset Park community and Brooklyn communities for decades. And I really value that insight, because it means so much to our community members to know that individuals who are making some of those structural decisions within our healthcare system are individuals that live down the street from them, individuals that they can call and say, hey, I've been having a tough time making an appointment at one of our sites. What can you do about it? There's that direct linkage between the care and the leadership that influences that care.
Thank you. That's ending our discussion on a really important point. And we're now turn it back over to Stephanie, who's going to bring us to our next activity.
Wonderful. Well, huge round of applause for all of you. Just a tremendous panel. I was over here taking notes and just being so inspired by your work, and especially the creativity, the flexibility, the ingenuity that you brought to the challenges that you described in the past 2 years. Really well done. There's so many gems here. Thank you for spending your time with us today. We hope you'll stick around for